moving these patients, so we have a certain number of patients when we start hormonal therapy, whether it's complete androgen blockade, LHRH agonist or antagonist, many of them do well, their PSAs stay low. But then unfortunately what tends to happen is that they develop this rise and now get into this new area that we call castration-resistant prostate cancer. So the problem that I see looking at my partners, talking to colleagues across the United States, is that we tend to follow their PSAs, and if the patients are asymptomatic or having no pain, we tend to look at PSAs and say, well, it's not very high, we're just going to keep watching them. It's a very easy visit. They come in, they get their shot, they ask a simple question. With our ever inefficient EHRs, it's a very easy visit and they're out the door. The problem is, as many of us know, the data is that many, as you mentioned earlier, a lot of these patients have asymptomatic metastatic disease despite having very low levels of PSA. So now we get into this whole management problem of early monitoring, early detection using imaging. Years ago it didn't matter because we didn't have that many agents. Now we have agents. So Steve, so you got a patient on androgen deprivation therapy, PSA starts to go up, maybe he's got a doubling time of about 7 months, his absolute value is 2.4. So tell us about imaging, what's out there in terms of besides traditional bone scan and CT?
So just as some of the advancements in both surgery and radiation, as well as therapies have expanded in the last years, the same is true, I think, for imaging. Traditionally we quoted that for a gentleman whose PSA was rising, whose PSA approached, say, 40, the chance of detecting the site of that rising PSA with the standard workup, which would be a CAT scan of the pelvis and technetium-99 bone scan, would be detecting out of 5 out of 100 men. So that's not very good. And so there's been a lot of work in this field to try to expand both the detection locally in the pelvis, and that was with MRI, which we discussed a little bit earlier, and with more advanced bone scans and maybe some other nuclear medicine imaging. So F18 sodium fluoride PET-CT has really expanded, and the studies have shown a sensitivity and specificity which approaches 100% in various studies. It's really an impressive technology to define bone mets in the setting of these patients.
So can you differentiate, because people, when you start talking about PET scans, when you talk about sodium fluoride versus choline versus, glucose, tell us a little bit about the properties that make sodium fluoride so much better and why that is different from your traditional glucose-based PET scan.
Right. So, the thing when I have to do peer-to-peer reviews, and this happens a lot because I think where we are in our guidelines, we have the word bone scan. So you can get a bone scan. But that really isn't a test anymore because now, as you said, there's multiple tests that exist that can really help us define patients with bony metastasis or beyond that. So originally there was technetium-99 bone scan, and what that could detect is osteoblastic activity, but you had to have a lot of it. So if you detect bone cancer on a technetium-9 bone scan, those patients had a lot of disease. F18 PET-CT, sodium fluoride PET, it only detects cancer in the bone on the nuclear medicine side. The CAT scan portion is going to look at the whole body, look at nodes, look at the things that we look at in the CAT scan. But the nuclear medicine part of the test is really just going to look at bone metastasis, and it's very sensitive and specific for picking those sites of disease up. But what about the other sites of disease? What about lymph nodes? What about soft tissue deposits? So there's really been two carbon-based approaches. One is C11 choline. The other is C11 acetate. And when you look at the data, there is a suggestion that C11 acetate PET, which is an agent that has some technical issues in that the agent has to be made and given to a patient within 30 minutes of making that agent. So it can only be done at some very logistically competent centers. You can actually find sites of cancer in patients with soft tissue metastasis as well as the bony metastasis, especially in patients with PSAs less than 2. This is a far cry, we think, from the days when we were doing CTs and Tec-99 bone scans and detecting 5 out of 100 men.
So my question to you would be, in the community, in a big city, this technology is available. If you go to Atlanta, Chicago, LA, these imaging modalities are available on a regular basis and can be ordered relatively easily. What about a practicing urologist in a smaller community, say in the Midwest, in Iowa? He has to drive 3 hours, 4 hours to a medical center where he gets pretty good care, but may not have this technology available. Do you recommend that all these patients, or how do you determine which patients should get sodium fluoride scans and which patients can you just follow?
Yeah, I think with the advent of glucose-based PETs, as we talked about, the ability to do a PET scan is really not the rate-limiting step in today's culture. I think that the problem has existed on a national level, that we've moved the target, but in many things in guidelines, but not so much on the defining what test we're actually using. So in my group, as an example, with 700 physicians in 16 states and 9 countries, in my location in Arizona, F18 PET, with the data that has been shown, is a approved modality. I've ordered it for the last 3 years. I've been only turned down once out of, in number of patients.
Is that for both commercial and Medicare?
Yes. However, in Michigan, my partners in Michigan, they have never been able to get an F18 PET-CT approved. How is that possible in today's world that we have such a variety across the U.S.? So I think F18 PET-CTs are available. The issue is really the reimbursement.
Right.
With respect to some of these other modalities with C11, whether it be choline or acetate, those, I think most of us today would consider experimental at specific sites. And we all know patients who will fly to whatever sites to obtain these imaging modalities. My personal philosophy is I don't throw the baby out with the bathwater. I start at the modalities that we used up front for a long period of time and work our way up to more expensive modalities. But I think that in today's world, if you can obtain an F18 sodium fluoride PET, you're getting the bone scan, you're getting the CT scan, and you're actually probably saving society some money than ordering those 2 tests.
Does C11 choline have the same restrictions as the C11 acetate?
I think those are 2 separate agents, and again, C11 acetate exists in very subspecialized centers in the U.S., and you have to have 2 $12 million cyclotrons to be able to make it and give it in a short period of time. We know for a fact that there's other imaging modalities coming down the pike even past this. But I think as a group of educated physicians, we know that that these patients that we call with the rising PSA in the M0 setting, from the studies that we've done, there's a large number of those men who actually have sites of disease. We just haven't detected them. And now, for the first time, we're going to actually be able to find their sites of disease.
Van,
So can you...
Go ahead.
Yeah, a couple of things. So that, first of all, before anybody starts working these people up and call them castrate-resistant, one of the things you need to do is check the testosterone,
Correct.
and make sure they're castrate less than 20, and then because you're gonna find 30% of your patients or more that aren't, and you can still benefit them. The thing about imaging is, as you well know, there's a shortage of technetium, and sodium fluoride's actually been around for a long time. It is very sensitive and specific, and but we have seen cases where people have had sodium fluoride PETs that were supposedly positive, that you go back and you look at MRs, you look at plain films and things like that that are not. So I worry about them being maybe too sensitive and not 100% specific. And then the other thing is we're doing all these C11 PETs and things like that,
You do them, but does it really make a difference in what you're going to do to the patient? So if somebody has a node, a small node in the aortic bifurcation, are you going to radiate up there if they've already been radiated? Are you going to give hormones? Or are you going to do anything different? Now, at least that's some of the feedback I'm getting from some of the third-party payers when we try to get things paid for.
I think my answer to that would be, as a radiation oncologist, we traditionally, like when we aimed at bone metastasis, we would do it on plain films, and if a lesion was, say, in a vertebra, we might aim one vertebra above and one vertebra below. Does that make a lot of sense in today's world? Probably not. With fancy imaging, like you said, if you had, say, a C11 acetate PET, which showed disease, say, a periaortic, which would be nowhere near the post-prostatectomy radiation field. Does it really make a lot of sense to apply post-prostatectomy radiation? Maybe the site we should be radiating is that site. And I think this is a very exciting area of development in the future because, again, there's only a few centers that actually have this kind of technology. I think most of us would follow a very rigid algorithm of who do we radiate in the rising PSA setting, a post-prostatectomy field. But what I find is with this technology, especially the C11 acetate technology, we're finding what we think is the defined areas of where the prostate cancer may be locally or distantly, which allows us now with the technologies that have developed in radiation to be able to focally pinpoint those kind of technologies.
So, but just to play the devil's advocate, so you do one and you find there's some periaortic disease, okay? Let's say the patient had radiation, failed, and the pelvis is clean. That's in sort of a critical area with a lot of stuff up there. And then, I'm always hearing that, we're increasing radiation doses as high as we can for tolerance, yet you can't use that same dose here, and you got a metastatic phenotype that's probably less sensitive. But, I would question whether there'd be any value to doing it at all. So, if I were sitting on the other side of that phone line, approving this choline PET, I would say, okay, I'm not sure that this is a valuable thing to do.
And, this is, for me, is a very, argument that as again, one who's trained as an NIH fellowship-trained surgical oncologist, we talked about the benefits of metastasectomies in the setting of various cancers, showing that there was this subset, 20% of patients who seemed to benefit from certain metastasectomies. I think we're going to find it's very similar in the range of using radiation techniques. And I think there's also some interesting data coming down the line. Our group is very interested in the ideas that radiation may potentiate some of the other things that we do in combination therapy, things like immunotherapy, like Provenge, and that by doing radiation, which we know from years in the lab, upregulates molecules and cytokines in class 1 and class 2, that we may be potentiating some of these things.
I think we all know, however, that as these patients, as they fail hormonal therapy and their PSA starts to go up, we know where they're heading. We know where they're heading. They're going to develop metastatic disease. Now, I think there's lots of things to put into the equation, but I think the fact now that we have so many therapies, and whether it be androgen synthesis inhibitors, androgen receptor agonists, immunotherapy, we know where they're heading, and now, hopefully in that high-risk category in the younger patient, we can actually institute therapy much earlier. So Van, you're in a big group, you run this, you run their advanced therapeutics, so do you have a protocol in place in this patient who's been on hormonal therapy, has a rising PSA? Do you have a trigger? Do you have a sort of anything in place to guide you when to get that first scan?
Yeah, so these are all great questions. The imaging really, as we evolve into better imaging techniques, we will be able to offer our patients therapies that before we could not. So imaging is very important, especially in the CRPC state. The way you image them, typically we image them when the PSA begins to rise, because we want to have a baseline. And if the imaging is, of course, negative, then we look at the PSA doubling time and the absolute PSA. And this is based on Matt Smith's data, showing that the higher the PSA doubling time or the higher the absolute PSA is, the more likely you are to have a positive image on traditional old technologies, that's going to become soon outdated, such as the technetium bone scan and the traditional CT scan. So we typically scan our patients based on our protocols anywhere between 6 and 18 months once they begin to fail ADT and are diagnosed as CRPC. That's kind of our range. And depending on, but if you go to Matt Smith's data, at 2 years, 46% of your patients will convert from the M0 setting to the M positive setting. And if we use better imaging techniques, as Steve alluded to, then probably that number will go up.
Now, you mentioned doubling time, and I think we all recognize that if you have a doubling time less than 9 months, they're at a higher risk. What about an absolute value? Do you have it, or do you just completely gestalt it?
Well, gestalt is a great word. There is a lot of gestalt in medicine. That's why medicine is an art. I think you have to look at the numbers, though. The PSA doubling time, I think, is an easier thing to track and determine than the absolute PSA. The absolute PSA, you have that already. But the rate of rise of the PSA, I think, is a very important criteria for how the patient's going to do and when they're going to develop metastatic disease.
Steve, so